Good morning, everyone. If my voice is clear and the screen is available to all of you, just say yes in the chat room so that we can start our free session for today. Hello. Yes. Thank you, Humaira. Thank you, Iman. Thank you. So before start discussing the topic itself, I just would like to say few things regarding part 2 MRCOG exam. As all of you are preparing for the exam or pass through the experience of the exam itself, the real exam, and could not achieve success, it doesn't matter. Now you should know that, yes, part 2 is difficult. Part 2 is a hard exam. Part 2 is a tough exam. All of these facts are true. It's really the most difficult part of MRCOG journey, part 1, 2, 3. It's more difficult than part 3. Yeah, indeed. But the difficulty, it depends on your brain set. It depends on your understanding of the policy of the exam. It depends on how much you are able to manipulate the question. It doesn't relate too much to how much you are knowledgeable, how much hours you are studying every day. It doesn't matter how many topics you covered. It's not mandatory thing to cover everything because it's impossible. Okay, let's say this. I passed. Many people passed. Do you think that we covered everything? No. No, nobody can cover everything. It's about the smart working rather than hard working. How can I achieve smart working successfully to cover the most important things? Number one, proper guiding. Find a body to follow. This body may be a famous workers in the field of teaching, like mid exam expert or others. It doesn't matter. Choose one, follow them. Number two, find a study partner within the same level of you so that you can keep moving together to help each other, okay? Don't choose a progressed one so that the differences between both of you will be huge. You will never be able to follow. And don't choose poor candidate who is not interested in the exam actually, who is not have a passion enough to pass the exam, so he will take you back and down. Try to find a suitable partner. Don't waste your time in many groups on Facebook, on Telegram. Just keep your eyes and your brain focused on your target with a certain people. This is number one. Number two, you have to understand that MRCOG Part 2 exam is a basic exam. It's not an exam for consultant level. It's not a CCT exam, for example. It's an exam for trainees. So it's supposed to be an easy or basic exam. Your brain set should be towards this. You are just a trainee. So questions are very basic. No tricks in the exam. Believe me, even if you find some questions tricky or some questions difficult, there is no trick in any question. It depends on your brain set. I read the question, you read the question. I will answer correctly, you may answer in the wrong way. Why? Because I understood the question, okay? All questions in part 2, it carries a keyword. Keyword. I'm not reading the question like I'm reading a story or something like this. I'm reading. It's not like this. I'm reading just to catch the keyword. If I catch it, I will answer correctly. Basically, it's very easy. But if I keep reading without catching the keyword, I will be lost. I will choose inappropriate answer. So your training should be on how can I read the question parallelly to what are the topics I need to cover. Not all topics important. TOG articles, for example, in the last 3 years, they are famous advice. Just read the TOGs in the last 3 years to cover the exam. Are all TOGs important in the exam? Of course not. Of course not. TOG released 4 issues per year. Every issue or folder contains about 6 to 7 articles. It means I need to cover around 24 articles annually. And then it's around 70 articles per year, 3 years. Too much. It's never like this. I have to select most important TOGs. What are the TOGs matching with my level as a trainee? For example, a TOG article for infertility, unexplained infertility. Yes, it could be important. Another TOG article discussing pre-implantation genetic diagnosis in IVF. Of course, it's not important in your exam. It's beyond your level. If you study this, so what will be the questions of infertility for a consultant level? So you have to understand this very well. If you would like to pass in part 2, the golden key for success is persistence. Don't lose your faith. Even if you failed once, twice, 3 times, don't lose your faith. Modify your pathway, reformat your brain, and then you will pass. Persistence is the most important thing for success, not an exam in your life. Nobody knows how many times I failed part 2 MRCOG. I swear of that. Nobody of you, all of you knows. Now you are just seeing Dr. Hassan is a good one in part 2 lectures and examiner in part 3. He's a good doctor. He's a famous one. Of course, he passed easily. No, it is not. No one knows what is behind the scene. No one knows how many times I failed part 3 and I failed in part 2. And I will never say that because I feel it's like a shame. I failed many times. Yeah, I failed many times, but maybe the most important thing in my character and my personality that I am a persistent man. I never lose faith in myself, okay, that I'm a good one. And I trust 100% God, he will reward me one day, as well as all of you. The God will reward all of you one day in the absolute time. So just keep moving and don't look around. Don't be disappointed and focus. This is the most important advice. Now, today, just we will give an example. How can we simplify any topic? I chose somehow difficult topic because it's not related to obstetrics and gynae. It's also depending on a difficult medical disorder with pregnancy. So it requires some knowledge about internal medicine and immunology and pharmaceutics or pharmacology. So we need to do some effort to finalize and simplify this mixture in an easy way. So let's start. I think it's a very famous topic and very important topic, either in single best answers for part 2, or it's a very famous station in part 3. Okay. So I will give you this topic in perspective of both part 2 and part 3. Many people suffered all around the world from renal failure. So they are in need for renal transplantation. As any grafts or any transplantations, a foreign body inside the body. So the idea is to prevent high-risk rejections, we need to suppress immunity of the body. We need to suppress immunity. So after a while, the immune system will recognize the graft, and later on, rejections risk will be very minimal. Okay. What is the problem here? The problem is pregnancy itself. It's one of the famous factors of immunosuppression. Pregnancy is associated with low immunity. So now you have to put the patient in double factors immunosuppression. Now the patient is at a high risk pregnancy for infections. Am I right? Immunocompromised patient under treatments of immunomedications or HIV or pregnancy, they are at higher risk of getting fatal infections. Despite these infections could be very simple, but because there is no immunity, they are turning into a fatal infection. This is the idea. How can we handle the stick from the middle? Do the immunosuppression and keep the patient in a safe zone against infections. Okay. Another problem, all of you knows that kidneys are playing a role as well in control of blood pressure. So patients with renal transplantation, they are at higher risk than normal to develop chronic hypertension, i.e. pregnancy-related hypertension. Furtherly, they may develop into preeclampsia easily, and all complications of preeclampsia could happen, like small for gestational age, abruption, eclampsia, intrauterine fetal death, and preterm labor. So we need to cover certain points related to that. In that sake, the guideline suggested that I need to do some important tests for a successful renal transplantation woman seeking fertility in pre-pregnancy counseling clinic. Now I need to just tell you small information about pre-pregnancy clinics. In UK, high-risk patients for pregnancy, they should attend pre-pregnancy counseling clinic just to evaluate the case. Is it eligible for possibly safe pregnancy, or the pregnancy will be high risk, so I have to prevent pregnancy. I have to advise the woman not to get pregnant and give her sometime reliable contraception. According to a certain parameter or certain parameters regarding each case, I can decide either the pregnancy will be safe or not. In transplantation, I have two important tests two important tests to evaluate is this patient is in a safe mood or not. The first one, logically, is kidney function tests, urea and creatinine, okay? Basically. The second test is more simple. It's regarding urine analysis. It is an amazing thing that serum creatinine also is not reflecting the kidney condition. It's also give a very good advice, a very good notice about is this woman may develop hypertension or not. So they suggest that serum creatinine should be less than 125 micromole per liter, okay? Successful obstetric outcome, nearly 100% if the serum creatinine is less than 125. But if it's more than this, 25% complicated pregnancies and up to 80%, complicated outcomes, and up to 80% complications during pregnancy may happen, like what we discussed before. So this is a very important parameter. So if I asked you in the exam, let's translate this information into an exam question. If I asked you, patient, she had a renal transplantation 2 years ago, which is stable, and she is now in a pre-pregnancy counseling clinic seeking for pregnancy. What is the most important test I can offer her seeking for a perfect outcome of pregnancy, looking for outcome of pregnancy? So simply, serum creatinine will be the ideal choice. Serum creatinine. This is the question, and this is how can I apply this knowledge for the exam. Okay. Pre-pregnancy, summarizing the criteria considering pregnancy, good general health in the last 12 to 24 months post-transplantation. I need to explain this two times. Most of you don't know this. It's in part 3, not in part 2, but I will tell you. If the woman has a successful renal transplantation and the donor was one of her first degree relatives, the maximum time of risk of rejection is 1 year, 12 months. Then she should not get pregnancy within the first year after transplantation. If the donor was from the first relative degree of the patient, her father, her mother, her sister, her brother, So I will give her 1 year follow-up without pregnancy. But if the donor is foreigner, not from the relatives, I need to follow up her and prevent pregnancy for 2 years, 24 months. That's why we need to evaluate the woman most probably for 2 years post-transplantation. This is the explanation. Good, stable kidney function. Preferably, serum creatinine should be lower than 125. No recent episodes of acute rejection. Most probably in the last 6 months. Hypertension. The patient is normotensive, or the patient is on minimal doses of antihypertensive medication. It means that The woman is stable, by the way. Recommended immunosuppressants are not interfere with pregnancy. I will discuss the immunosuppressants in details because you need to know some important information regarding them. Okay, so these are the criteria in pre-pregnancy counseling appointment I need to check. The most important test, serum creatinine. Now, regarding the medications prescribed in a case of kidney transplantation, patient should receive number one, immunosuppressive medications. What are the immunosuppressive medications you know from the practice? Simply, just a second. Yeah, I just need the pen. Okay. Simply, prednisolone, large molecular weight corticosteroids, is the most famous immunosuppressant medication used. Prednisolone is safe in pregnancy simply because large molecular weight steroids are not passing through the placental barrier. On the other hand, if you can recognize this, dexamethasone and betamethasone are low molecular weight steroids. That's why we use them for lung maturity, but they are weaker than prednisolone. Tacrolimus, it's a famous immunomodulator. Tacrolimus, it works on T helper lymphocyte suppression. So TT, it's famously used as alternative treatment or second line treatment in lichen sclerosis, vulvar lesion, if steroids failed to manage the situation. Cyclosporin A, it's a very famous and safe medication, as well as azathioprine. All of them are immunosuppressants, and they are very safe. Very safe. You can see them here, all of them. In some cases, hydroxychloroquine or Plaquenil can be used as well. So the conclusion is all immunosuppressants medications are safe to be used in pregnancy and breastfeeding, except two treatments. Which are the two treatments? Mycophenolate mofetil is a famous immunosuppressant which is typically teratogenic, so should not be used in pregnancy. Single best answer. The only treatment, medication. Any other medications? Yes, they are not medications actually. They are a new era of treatments which called biological therapy. A specific antibodies injected in the body to treat cancers, to suppress immunity, to do many things. They are called biological treatment. Famously, rituximab. But unfortunately, there are no data enough to judge are they safe in pregnancy and breastfeeding or not. So in exam, you will avoid them typically. So simply, single best answer. Immunosuppressants, I know all of them. I should avoid mycophenolate, biological treatment. Okay, any other treatments that the patient should receive? Typically, yeah, antihypertensive medications. All of you knows that in antihypertensive medications in pregnancy and breastfeeding, labetalol is considered the best first line treatment. Am I right? Labetalol. Exactly, antihypertensives. So labetalol is perfect. I agree. But sometimes labetalol is not safe in pregnancy because the patient may be asthmatic, bronchial asthma. So labetalol is contraindicated with bronchial asthma. Put it in your mind. Or if you would like to be working in a smart way, smart studying, let me ask you a question. What are the contraindication or contraindicated medications with asthma? Collect ideas together. Collect all of them together. Can you tell me some medications that I could not use them with asthmatic patient? Brainstorm.
Labetalol.
Labetalol, one of them. Yes. Any other medications in your mind?
Beta blocker.
Beta blockers. Atenolol. I agree. Beta agonists, antagonists. Yes. Beta blockers. Not particularly in hypertension.
Because it aggravates the asthma.
Any other medications? Not in a high.
Carboprost. Pethidine, sir.
Prostaglandins. Either carboprost, F2 alpha, or E2.
Pethidine.
Yes, prostaglandins. What about methergine? Should not be used. And more famous medications. What about non-steroidals? Anti-inflammatory medication. It should not be used as well. Am I right? So if you would like to summarize, non-steroidals, labetalol, misoprostol, carboprost, non-steroidals, methergine, and I know it's difficult to remember this, but I will tell you because I collected all of them before. Ulipristal acetate. Anybody study emergency contraception? Anybody knows emergency contraception? Ulipristal acetate should not be given for asthmatic patient. I'm right. So after this, any question related to contraindication with asthma, you will be able to remember them easily. Collect information so the study and revision will be more easy. Okay. Nifedipine is a very good alternative for control hypertension in patients with renal transplantation, and it's safe in pregnancy. Okay, it's also safe in breastfeeding. That's great. What else? Hydralazine is not used nowadays. It's an old vasodilator treatment. Okay, any other medications I may think about? Any other medications for a renal transplantation with pregnancy? Amlodipine, I have some disagreement with amlodipine. Amlodipine is used more to control arrhythmias. It's prescribed to control arrhythmias rather than just control the blood pressure. So you will never choose it in the exam. You may think about ACE inhibitors. By the way, ACE inhibitors are safe with breastfeeding, but they are not safe with pregnancy. Okay, but amlodipine, it will never be used in hypertension control in exam. Better to be used in arrhythmias. Okay. Now, any other treatments? Yes. Yes. Aspirin. Why I need to use aspirin in this patient? Any idea? If you can understand the fact, you will be able to remember. If you're just memorizing the facts, you will forget them. Believe me. So I need you to tell me why I will use aspirin, for example, in this patient. Is she at risk of VTE? This is a very common mistake in Part 2 exam. I know most of you in your practice, including me as well, we are using aspirin as anticoagulant. If the woman is high risk of VTE, I will give her aspirin. It's not like this in UK and in exam. Aspirin is just used to prevent hypertensive disorders in pregnancy and preeclampsia. Thank you. This is the game. So if the woman, look at this, if the woman is at high risk of VTE, she is positive thrombophilia, she had a previous history of DVT or other risk factors, I will prescribe her low molecular weight heparin. Okay? But aspirin, starting from 12 weeks of gestation and maximally never beyond, you should never start aspirin beyond 16 weeks, is prescribed to prevent abnormal placentation, microangiopathies. So it decreases the risks of preeclampsia and hypertensive disorders, which are common with renal transplantation patients. So I will prescribe her aspirin, which is definitely safe in pregnancy and breastfeeding. Am I right? What about this treatment? Erythropoietin. Many years ago, I had a staff round on patients in my hospital. We had a patient. She was admitted because of a pyelonephritis with pregnancy. Okay. With tests and investigations, we discovered severe anemia. And we asked the patient, she said, I'm regularly taking iron supplementations, okay? And there is no bleeding source, no malabsorption, nothing at all. As well, she is regularly taking vitamin C. One of our brilliant consultants, he was with us, and then he said, just give her an injection of erythropoietin and repeat the test of hemoglobin. I don't know why. The patient's kidneys are working, but yeah, pyelonephritis, but they are working. I give her erythropoietin, and dramatically, hemoglobin is elevated. Erythropoietin secreted by kidneys is essential, important factor for hemoglobin formation. So with kidney patients, chronic kidney patients, even if they are stable, erythropoietin could be prescribed to correct anemia. Now, how can I apply this information in the exam? Anemic patient with kidney problem. She's regularly taking iron and she is not improved. What is additionally I can offer her? Now listen to me. It's very important trick. If the hemoglobin is not improved and the patient is anemic, despite iron intake, iron supplementation, if the question asked me about what further treatment I can give her, so answer erythropoietin. But if the question asked me what is other tests I may offer for her, you should think about another problem rather than the kidney. The kidney may be a distractor. Famously, and the most common cause for chronic borderline anemia patients is thalassemia minor. Thalassemia minor patient, the hemoglobin is always 8.59 maximally, despite receiving iron, because she will never utilize the iron. The problem is not in iron, the problem is in hemoglobin. a part of hemcoagulopathies. So you will choose hemoglobin electrophoresis. Okay, I need your vision to be broad. You need to imagine the whole situation so that you can choose the ideal option. Anyway, these are the treatments. Okay, of course, you know that warfarin is not prescribed, particularly in the first trimester in pregnancy. So if the woman is taking warfarin for any reason, it should be replaced by low molecular weight heparin. Okay, that's easy. I think it's easy. Please don't forget infections. Now, I will summarize pre-pregnancy for any case, and then choose the most appropriate points regarding renal transplantation. In pre-pregnancy counseling session, we actually do analysis of complaint. I will analyze the problem, details, onset, course, duration. Then I will discuss with the patient about medications. Medications most probably has two pathways. What are the medications the patient already taking? So I need to revise them. In renal transplantation, patient is taking all of these medications. I will revise them. Any medication is interfere with pregnancy or contraindicated in pregnancy, I need to stop it. I need to change it to more safe treatment. This is part one, the first pathway. The second pathway is, what are medications I would like to offer for her to help her in a safe pregnancy? Famously, folic acid should be given prior to pregnancy, plus basically to all women, vitamin D. All women should be offered vitamin D all through her pregnancy. Great. And after giving folic acid, vitamin D, and medication review, I will move to the third point. Any investigations I need to ask her for prior to offer her safe pregnancy? Yes. In renal transplantation, I will check serum creatinine and kidney functions. Okay. I will check her blood pressure. For example, if you are going to evaluate diabetic woman, type 1, what kind of investigations I would like to ask her for prior to allow her to get pregnancy? Glycosylated hemoglobin. I'm right. Hemoglobin A1C. If the woman is thalassemia major, I will check her heart condition, echo, and cardiac MRI. So I can apply these rules to any medical disorder with pregnancy in pre-pregnancy counseling appointment. Keep them points in your mind. And finally, I need to check vaccinations for high-risk patients for infections. This group of patients, including HIV with pregnancy, immunosuppressants medications regularly taking either in renal transplantation patients or other autoimmune diseases like SLE, like antiphospholipid syndrome. Some medical disorders that the patient is vulnerable for infections, like type 1 diabetes, like asthmatic patients. So I will offer them prophylactic vaccinations prior to pregnancy, like pneumococcal vaccination, influenza B vaccine, and meningococcal vaccinations. Plus, all of you knows that rubella check is not anymore part of routine antenatal investigations, booking investigations. Now, we need to check rubella, if possible, in pre-pregnancy situation. So just remember rubella with vaccinations. Now, the pre-pregnancy counseling after these 4 points is almost covered successfully. When the patient gets pregnant, the antenatal care, the first visit or the booking visit should be as early as possible, okay? I need to offer her the routine booking visit tests, including full blood count, red cell ALO immunization, ALO antibodies check, RH grouping, MSU, HIV, HPV, and syphilis screening. Moreover, I need to check for venous thromboembolic risks assessment. Keep giving her folic acid, aspirin starting from 12 weeks, and otherwise she will be reviewed by kidney function tests every month, as well as MSU every month for proteinuria and checking baseline renal functions, and blood pressure should be checked every 2 weeks. So again, baseline assessment, renal functions, and it will be repeated every month. Urine analysis for proteinuria every month, and blood pressure every 2 weeks. In subsequent visits, don't forget to monitor blood pressure. Don't forget to monitor renal functions, proteinuria, as we discussed. Full blood count will be repeated around 28 weeks, as well as the red cell antibodies, ALO antibodies. It's very important here to remember that some medications, like tacrolimus, levels should be checked because toxicity of the treatment may occur. So it's extremely particular important knowledge for SBAs. Tacrolimus should be evaluated and monitored, okay? In nice hypertension, aspirin is started less than, from 12, definitely 12 weeks, never more than 16 weeks. If the patient came after 16 weeks, for example, don't offer aspirin. Other articles, it started at 12 weeks. No contradiction, no conflict, my dear, okay? The NICE said started ideally 12 weeks, but it's allowed to offer aspirin up to 16 weeks, but not more than 16 weeks, because after 16 weeks, actually, full developed placentation is happened. So no rule for aspirin after 16 weeks. You got my point. Spiral arterioles invaded the myometrium and the endometrium. So after 16 weeks, full placentation formation is done. But I can typically start aspirin starting from 12 weeks. So no conflict, my dear, between any article and the NICE guidelines. Okay? Perfect. So don't forget the tacrolimus. What about the time of birth and the mood of delivery? Ideally, why start from 12 weeks, not earlier, sir? Some authors considered aspirin associated with some anomalies and some problems with the baby development if started before 12 weeks. It's not evidence-based. it's just some sporadic, systematic reviews. So the evidence base is it's safe starting from 12 weeks. However, in practice, I used to start aspirin as early as possible, and there are no complications actually. Okay. But for exam, I will subside my practice away and I follow the instructions. The timing of birth needs to be evaluated by the multidisciplinary team. Now, with any high-risk pregnancy, you need to remember these facts. High-risk pregnancy should be evaluated and followed in consultant-led unit, not in midwifery unit. And in consultant-led unit, many people will keep eyes on the patient. Your consultant, fetal medicine consultant, in this case, nephrology consultant, psychological counselor may be involved because the patients are mostly stressed, cardiovascular consultant, and so on. Near the time of full term, consultant anesthesia should be involved as well in the loop to evaluate the best mood of painkillers or the anesthesia mood for this patient. So the time of delivery in complicated scenarios is different. No fixed time. It depends on the stability of the patient. But if the patient also is stable, no complications, I can offer her delivery 37, 38 weeks of gestation. Okay. Of course, you know the fact that vaginal birth almost in 99.9% is recommended over cesarean section, unless in renal transplantation we have one famous indication for elective cesarean section. If their transplanted kidney is low in the pelvis, near the pelvic inlet, so it may interfere with vaginal birth, a kind of obstruction. In this scenario, elective cesarean section should be ideal option for delivery. Otherwise, no indications if the patient is stable and the baby is stable. Go for vaginal birth. Okay. I will give you a very important tip, by the way, not only related to renal transplantation, any complicated pregnancy, uncontrolled hypertension, uncontrolled diabetes, deteriorated renal transplantation with pregnancy, renal flare up with systemic lupus, any condition, in complicated scenarios, the full term is considered 34 weeks of gestation, not 37. Let me give you a very simple example. If you have a case with severe preeclampsia, 30 or 31 weeks, okay? How can I manage this patient? I will first try to stabilize the patient. And observation or conservative treatment is the ideal way because of the prematurity. So I will stabilize. If the patient is improved and now she's stable, I will wait. I will not terminate pregnancy right now. Till when? Till when? Till 38 weeks, for example? Till 40 weeks? No. After 34 weeks, after 34 weeks, if there is any deterioration, mild elevation of hypertension, I will terminate pregnancy. This is the full term, okay? This is the full term in complicated pregnancies. It will be the same with renal transplantation. With renal transplantation, if any deterioration happened, I will terminate maximally by 34 weeks. In intrapartum and postpartum management, the aim is for vaginal birth. Only cesarean section for obstetric indication or toased kidney. Toased kidney means the kidney is low position in the pelvis. It's very important to deliver the patient in the hospital, no options for home birth or something like this, under close observation for the mother's vitals and the baby's monitoring as well. Okay. In the postpartum period, I have to follow the fluid balance, checking the toxicity of tacrolimus, thromboprophylaxis automatically for 6 weeks if there is a positive proteinuria. This is a very important information in single breast answers. In breastfeeding, prednisolone, azathioprine, cyclosporin are accepted. Mycophenolate mofetil is contraindicated, as well as the biological treatment as we discussed. Angiotensin receptor blocking agents, ACE inhibitors as antihypertensive medications. It may lead to neonatal hypotension. However, enalapril, captopril can be used. So they are not absolutely contraindicated in breastfeeding, okay? So if no proteinuria, then low molecular weight heparin? No. If no proteinuria, so assess the patient as any other patient for risks of DVT. So you can take a look for PMI, you can take a look for the vaginal birth, it was prolonged or not, instrumental or not, amount of postpartum hemorrhage. It will be evaluated like any other woman. Proteinuria only with renal transplantation patient, if positive, go directly for 6 weeks low molecular weight heparin, regardless other factors. Thank you. Surprisingly, contraceptions, what kind of contraception I can give the patient? Okay. What do you think regarding contraception? Intrauterine device is almost good option for those patients. However, some authors don't accept the ICD because the patient is immunocompromised and then there's a risks of ascending infection. Am I right? So what do you think about combined pills or combined hormonal contraception? If the patient is at risk of DVT, so combined oral pills should not be offered. This is very logic. So finally, I will go for POPs, progesterone only pills. This is a good method with no adverse effects on renal transplantation, no effect on risks of DVT, and it's not associated with high-risk infections. What about the barrier method? Let's say that I need to prevent pregnancy in this patient. So barrier are safe, but not reliable methods. Failure rates are high. So I could not offer barrier methods in high-risk pregnancy patients. I will go for POPs, by the way. Key points, just to summarize, 70% of pregnancies are proceeding or progressing very well. Complications may be hypertensive disorders, preterm, intrauterine fetal death, and intrauterine growth restriction. Pregnancy seems to be good outcomes if the renal function serum creatinine less than 125 with no graft rejections attacks. In pre-pregnancy, I will just remember the 4 points. Analysis of complaint should be 2 years without any episodes of rejection. Medications, I will revise all immunosuppressants, stop what I need to stop, add folic acid and vitamin D. Investigation, serum creatinine is the most important test. Check for vaccinations, particularly give vaccinations for pneumococcal, influenza, meningococcal, and check rubella status. In antenatal, don't forget to repeat kidney functions and urine tests monthly and blood pressure measurements every 2 weeks regularly. And most importantly for SBAs, tacrolimus should be measured in serum levels regularly because there is a high risk toxicity possibly. In birth planning, vaginal delivery is superior than cesarean section, except in certain conditions. MDT should manage whole pregnancy, and patients with long-term steroids for immunosuppressions should be offered hydrosteroids, hydrocortisone, intravenous steroids covered during labor. In intrapartum, close observation for the mother and CTG continuously for the baby with good monitoring of fluid balance. And postpartum, don't forget the fluid balance, recheck tacrolimus level, review medications, choose reliable contraception, mostly POPs. The topic is finished. No more questions. No more surprises regarding this topic in exam. Why prophylaxis for meningococcal and pneumococcal? You have to tell me about this. Why? Is the patient at risk of getting infection? She has double factors for low immunity. She's taking immunosuppressant medications. She is pregnant. 2 factors. So definitely she is a very weak patient to minor infections. If she got pneumonia, she will die. Imagine that. So of course, I need to give her prophylactic vaccinations. I wish that after this session, all of you, of course, maybe anemic as well. Of course, after all of this session, I wish that renal transplantation with pregnancy is easy. But this is not my aim. This is not my aim. My main aim is, can you apply the same technique of summarization and catching points by same rules like this over diabetes, hypertension, asthma, epilepsy? Can you do this? If you can do this, go and do this, and you will find medical disorders with pregnancy very easy. If you apply the rules, fulfill the spaces according to each situation, you will find this very easy. Try to do this. This is your homework. For example, candidate 1 will take diabetes, candidate 2 will take asthma, candidate 3 will take epilepsy. Do your notes, write the principles, evaluate, send them on the Telegram group, for example, and discuss. After this, you will be able to cover any medical disorder with pregnancy by logic. Okay? This is my main aim, actually. It's not related to renal transplantation, by the way. I would like to thank all of you to be with me in this session, and I wish that all of you gain the maximum benefit. Thank you so much for being with me for more than 1 hour, and hope to see all of you very soon. If you have any questions, by the way, you can send it to the groups of med exam expert, mention me or mention one of our dear mentors, and all of us will be there to answer any queries. Thank you again, and best of luck to all of you, my dear friends. Have a nice day. Bye bye.